Good evening, ladies and gentlemen. Welcome to our next session, Subfertility, Innovations in Assisted Reproductive Technology. I would like to welcome the moderator for this session, Dr. Gayani Tissera, a Senior Registrar Reproductive Medicine, Casa Street Hospital for Women under the Ministry of Health. She is also a visiting lecturer at the Faculty of Medicine, Wayamba University, and she is also Suffolk Young Gynecology Award winner 2023. I would like to welcome her to moderate this session.
Thank you, Nadika, for that kind introduction. Good evening, ladies and gentlemen. This is the last session of International Conference of Sexual and Reproductive Health, which is named Subfertility and Assisted Reproduction. Subfertility is a significant problem among the reproductive population. It affects the significant amount of reproductive population. So it's a very important topic to discuss. And also it's with the advancement of the technology and the treatment modalities and investigation modalities has been developed to a next level, and world has evolved to the level that they are planned research on artificial wombs. But however, today we are going to discuss about the core aspect of the infertility, which is based on assisted reproductive technology and male factor infertility and fertility preservation. To start today's proceeding, let me invite our senior professor Athula Kaluarachchi sir to chair this mini symposium. Well, we'll start with the first lecture. Introduce first lecture, Dr. Udara Jayawardena, senior consultant subfertility specialist attached to Colombo North Teaching Hospital. Over to you, sir, to talk on overview of assisted reproductive techniques.
Good evening, ladies and gentlemen, and thank you very much, Gayani, for your kind introduction. The topic I'm going to briefly discuss, of course, is about some of the developments that have taken place in the ART field over the past 40 or more years. So simply, in simple words, ART or IVF as commonly known is the most advanced technique that is available today all over the world for treating patients who are suffering from infertility. So simply, it is actually taking an egg outside the body and taking a sperm and allowing them to join each other in a laboratory setup, and after a certain number of days to transfer it back into the woman's womb, so it will be retained and persist, giving as an end result giving a live birth to a live baby. So the first IVF was done several decades back. It was done in 1978. It was actually Dr. Patrick Steptoe and Robert Edwards who performed a successful IVF, and as a result a baby girl was born in July 25th, 1978. That was about 46 years ago. And over the past 46 years, a lot of changes have taken place in every aspect of IVF. So if we broadly divide treatment cycle of IVF, I can divide them into controlled ovarian stimulation, a small surgery called oocyte retrieval, and then the fertilization of oocytes and allowing the embryos to grow, and then transferring it back. So there are advances, changes that have taken place in protocols to make the treatment more efficient and also to make it more safer for women who are undergoing this treatment. Several fertilizing techniques are available. The first all these techniques are still in use. Most commonly used ones are the conventional IVF and the ICSI, but depending on the issues that are in the spermatozoa mainly, sometimes other techniques like PICSI or IMSI also can be used. So the first thing, how it started was initially the sperms and the eggs were mixed in a petri dish in favorable conditions, and those sperms will go and fertilize the oocytes. This is somewhat similar to what happens inside the body. But sometimes what happens is if the sperm count is very low, the sperms are not good in quality, we have to try new things to make the eggs fertilized. So that is how the other techniques developed. In ICSI, for example, what happens is the embryologist catches a sperm and it injects and he or she injects it into the oocyte itself. So that will improve the chances of fertilization. Similarly, in PICSI, these actually techniques of selecting better sperms. So PICSI, it's a physiological technique, and what happens is we have to put the sperms into hyaluronic acid, and it's to see which sperm is the best to be used for fertilization. Similarly, IMSI is a technique where we look under the microscope and increase the magnification to about 6,000 and select the best sperm. So these things have evolved over the time, but still even the simplest form is in use. And also the technologies to evaluate embryos a lot of things have changed in this. Mainly, there are techniques to evaluate whether the embryo is a normal embryo, and also there are techniques to evaluate a growing embryo. So usually what happens was, after fertilization, we have to keep the embryos in a normal incubator. That is to provide the environment which is similar to inside a womb, so that the embryos will grow satisfactorily. So usually we have to evaluate it on day 3 or day 5. So if you are doing it in the normal route, we have to take the embryos out and look them under a microscope and then see whether they are progressing well. But there are new techniques where now there is a camera that is inside the incubator. So this is called actually embryoscope, time-lapse imaging. So in this technique, the embryos are not, there's no need to take the embryos out. So if you take the embryos out, there is a change in the environment for a short period of time, which might have an effect on the quality and the progression of the embryo growth. So, and also it is a better technique of finding out which embryo is the best. So this is what you get in an embryoscope. This shows how the embryo progresses over time. So we keep it inside for about 5 to 6 days, until which it becomes a blastocyst, which is the best embryo that can be transferred back, and it's more likely to be retained and give rise to a successful pregnancy. And this is another area, pre-implantation genetic studies. There are two main types actually. One is called PGT-A, the other one is called PGT-M. What it basically does is, it's a genetic test that is done on some tissue collected from the embryo and see whether the embryo has the normal genetic composition. If it's a normal embryo that is transferred to the womb, it is more likely to give rise to a normal baby. That is because some of those embryos may be abnormal as far as the genetic composition is concerned. This chance of having an abnormal embryo rises with the maternal age. That's why the older women are more likely to get children who are having genetic issues such as Down syndrome. So this is how you take a biopsy. For example, I'll take Down syndrome again as the example. If you look at the left side, this is a karyotype of a normal embryo. We know that it has 46 chromosomes or 23 sets of chromosomes. But on the left side, you can see the 21 set has actually 3 chromosomes. So you can't detect it unless you test it. So sometimes you might even transfer an embryo that has these genetic abnormalities. So this is called looking for aneuploidity. But there are so many genetic issues, we can't check for everything. So sometimes there are certain illnesses that can be identified in the family tree. So for those kind of couples, we can look at those genetic mutations specifically and eliminate the ones who have those problems and transfer only the normal embryos. That is the advantage of doing this. And of course, the success rate. Some centers, of course, uniformly perform PGT on embryos. But in, of course, our setup, I think even India probably, we do specifically only. If we find that the couple is at a higher risk of having abnormal embryo, then we would recommend to have this test done. But it is also duty of the clinician to educate every patient or couple who undergoes IVF about this procedure. So even when they're at a lower risk, they can make a decision whether they want to test it or not. Because even in younger women, sometimes we can see Down syndrome. So there are techniques of evaluating the endometrium. So finally, once the embryo is prepared, we have to transfer it back to the womb. And inside the womb, there is a tissue called endometrium. This is the tissue that the embryo gets implanted into. So if the endometrium is less receptive, again, even though how good the embryo is, it might not get implanted. So there are some tests that can be done to evaluate this and make changes accordingly. So there's this one concept talks about a window of implantation. It means that the endometrium is not receptive to embryos throughout the cycle. It is only receptive for few days. And this few days is called the window of implantation. It roughly corresponds to day 19 to 21 or 22 in a woman who has regular 28-day cycle. But sometimes in some women, the WI could be earlier than that, or in some, it could be later than this. So if you put an embryo outside the period of WI, then it is less likely to be retained. So in patients especially who have undergone IVF and who have had recurrent implantation failure, this is one of the techniques that is used in the world to evaluate whether we have the embryo at the right time. So this is known as endometrial receptivity analysis. So this test, we have to take a part of the endometrium. Actually, we have to do a mock cycle, just prepare the patient just as for embryo transfer. And we have to take a piece of the endometrium on the day where we will usually do the embryo transfer. but we don't actually transfer it because this is just a test. So we take a piece and then analyze it and see whether the tissue is in the receptive phase. So if it is in the receptive phase, it means we are planning to transfer the embryo at the right time. But sometimes the test will say it's pre-receptive, and sometimes it will say post-receptive, and it will also give a prediction about when to transfer the embryo. So that is one of the techniques that can be used in recurrent implantation failure. In addition, the artificial intelligence, of course, like in all other fields, will increasingly important role in our field as well. So in the future, we will see more and more things happening in AI, probably in embryo selection, and then sometimes the robotics may come in. So many things which we can't predict right now, actually. And also, I think in the future, this is still happening at the research level, but in the future, the stem cell researchers, stem cell treatments also may have a big role to play. The stem cells are cells that can differentiate into any type of tissue. These are called potential cells. So if that is the case, we can use these cells to regenerate tissues. For example, if the endometrium is damaged, we can use these cells to regenerate the endometrium, so that person will have a more favorable receptive endometrium. So those are the areas actually I wanted to speak, because it's a very limited time and we can't cover a lot of areas. I think the next two speakers, of course, will speak more about some other fields. Thank you very much for listening. Thanks.
Thank you, Dr. Udara, for that interesting overview of assisted reproductive technology. Let me invite our next speaker, who's Dr. Chaminda Hunukumbure, Head Department of the Faculty of Obstetrics and Gynecology, Faculty of Medicine, University of Jayawardena. And he will be delivering the lecture on male factor infertility, which is an emerging crisis in the field.
Right. It's a pleasure to be here. Thanks for inviting us. Right. It's about male factor. And what I want to discuss is basically we need to know the size of the problem that we are dealing with, how we are diagnosing it. I don't think it's nothing much new that you need to know about, but we'll discuss it anyway. I want to spend some time on the way lifestyle factors could affect male factor infertility, because it's quite important, because these are modifiable things. And the basics of management. I am not going to deal with the advanced techniques, but the basics. There are certain principles I want to deliver to the audience. So if you go by the original definition that was laid down by the American Society of Reproductive Medicine on infertility, where they come out with the definition of not being able to produce a pregnancy after actively trying for 1 year duration, we will find that about 15% of the population will end up with having a problem in starting a family. Now, if you divide that, then you will find that the males will be responsible altogether towards about 50% of the cases. In about 30%, they will be solely responsible. In about another 20%, they will have a part to play with their female partners. If you look at it, it says that the female factors will be about 50%. But remember, female factors are divided into several subtypes, like anovulation, tubal factor, anatomical and peritoneal factors like endometriosis, fibroids, and so on. So male factors are come up in one chunk. So as a result, they are considered the biggest contributor to infertility. Unfortunately, we don't see that many males in our clinics. It seems that the males are hiding behind their female partners when it comes to infertility. They just push them forward because it has a lot of social consequences. So they become targeted and they become the victims of all the psychological and social harassments that accompany not being able to conceive. So if you look at it from a global perspective, you can see that where we stand, where our region stands, whether it comes to primary infertility or secondary infertility. Primary is where they have never been able to conceive before. Secondary is where they had a successful conception, but they have found it difficult to fall pregnant again. This is where we stand. It's a global problem, and the incidence and the prevalence are rising, both when it comes to male as well as female infertility. Now, IVF has been described as one way out of it, especially when it comes, as Dr. Udara said, especially when it comes to ICSI, cytoplasmic sperm injection, because it has given us the opportunity to achieve pregnancies in situations where the semen parameters are hopelessly abnormal. Even they could father a child with thanks to ICSI. And these are data that has come up from the Human Fertilization and Embryology Authority, which is a regulatory body in the UK, almost 40% of the IVF cycles are carried out for male sector infertility there. Coming to IVF, you can see that the number of IVF centers are booming around the world. This is data from 2012, so it has improved much now. Where you can see where we stand as a country. Now look at if you consider it from an industry perspective, if you look at the market share, you can see that investigating and managing in male infertility has a lot of scope. So it's going to improve in the years to come. So what are the objectives of evaluating male factor or males for infertility? There are certain conditions which are curable. For example, things that have problems with people who have problems with their higher centers, the hypothalamus and the pituitary. You just replace the necessary hormones and then you expect things to kickstart. There could be certain conditions which are irreversible. Many of the patients will come up with conditions that are difficult to diagnose. We don't know what's basically happening with them, but their sperm parameters are tremendously abnormal. So in those things, they might find solace in assisted reproductive techniques like ICSI, plus or minus the other techniques like IMSI and PICSI that Dr. Udara told you about. If that is not the case, if their condition is not amenable to any of the treatment that we have discussed, we can offer them some other form of management. For example, going for donor insemination. And if that is not palatable to them, we can offer them adoption as a final solution. Sometimes, rarely, we might come across things that we did not expect. For example, life-threatening cancers in a patient who might initially present to us with a failure to conceive. Right? And there could be certain conditions that we might discover which has a potential to be transferred to the next generation. Even. So these are the objectives of evaluation. Now, the basic investigation that is being carried out is the semen analysis. So it requires about 72 to 96 hours of, that means 3 to 4 days of ejaculatory abstinence. There could be people who might think that abstaining longer would help to improve their parameters, but that is not the case. It is counterproductive because the number of dead sperms will increase if you abstain longer. So how we define abnormalities, we go by these reference ranges that have been laid down by the World Health Organization. So they have been periodically upgraded and they have come up in December 2021. So you can see how things have progressed. Now remember, these are reference ranges. They are not normal values. We will never know what the normal value is because we are not going to examine everybody that we come across. There could be people who have fathered many children whose values, if you evaluate them, their values might be much worse than what we see here. But they will never come for assessment. So what we have are not normal values. These are reference ranges. So there are certain terms that we use when it comes to defining abnormalities. So if the concentration is 0, if there are no sperms to be found, we call it azoospermia. If it is less than 15, between 0 and 15, we call it oligozoospermia. If there's a problem with motility, it's actinozoospermia. If there's a problem with morphology, then we call it teratozoospermia. The important thing to remember is, because of the reasons that I told you a little while ago, that these are not normal values, you don't go by a single reading. If something is not in par with the reference ranges that we just had a look at, then you need to repeat the test before you come to a conclusive diagnosis. Can it have an effect on the general health of the individual? People have done research on it and they have found that this is indeed the case. So anybody with the impaired male reproductive health, they have problems with their general health status. And some have even gone to the extent of finding an association with certain types of cancer. People with male infertility, like testicular cancers as well as advanced prostate cancers. And there is a likelihood that these individuals might face a premature death. There's a higher mortality risk. People who have abnormal sperm parameters more likely to have metabolic syndrome, and vice versa. People with metabolic derangements are more likely to have problems with their sperm parameters. And the problem is sometimes these things can transcript generations and can be transmitted to the next generation as well. About lifestyle, remember these are extrinsic factors that can affect the semen parameters and infertility. The important thing to remember is that most of these are modifiable. So obesity is well known that they can have problems with oligozoospermia or azoospermia. And some people have thought that IVF is a way out in these conditions, but there is research evidence to suggest that even if they go for IVF, their chances are not as high as in a person who is having a normal BMI. Diet, it has been a known fact. I mean, that diets consist of things that are high in antioxidants like vegetables and fruits, things that are high in monounsaturated fatty acids. They improve semen parameters. On the contrary, people who consume a lot of processed foods, those with saturated fats as well as sugary beverages, they are likely to sustain poor semen quality. And that is the fact. Now, there are certain trace elements that have been found to be beneficial when it comes to male infertility. Those are the ones that we include in the antioxidants that we include in the therapeutic preparations that we offer these patients. Because the oxidative stress can have a multi-pronged impact on the semen function. They can produce damage in more than one way. There is good evidence to suggest that antioxidants are beneficial. However, you need to take it with a pinch of salt, because most of the studies that have been included in these systematic reviews are not of very good quality, and there are a lot of confounding factors and they are underpowered. So although they look very promising, they might not deliver when it comes to in practical terms. Smoking, we all know that smoking has numerous detrimental effects when it comes to so many health aspects, which includes fertility. However, that is something that is interesting, is people think that e-cigarettes and vaping is less harmful, but there is evidence coming up from animal studies which suggests that exposure to the contents of e-cigarettes can be detrimental to spermatogenesis. Alcohol, habitual alcohol consumption is associated with poor quality semen. However, the researchers have not found a direct association with occasional alcohol intake. Caffeine, remember caffeine is there in coffee, tea or cocoa beverages. Even the PC drinks, the cola drinks that you consume, contain a considerable amount of caffeine, right? And they have been associated with particularly DNA damage in the sperms. Stress, psychological stress is related to the elevated serum corticosteroid levels, and they can have a negative impact on the sperm counts and sperm parameters. However, the interesting thing is that if the treatment itself can have a negative impact, you give antidepressants to alleviate stress and anxiety, that itself can have a negative impact on sexual function and sperm quality. Similarly, it's same with sleep. Now, sleep has an effect on numerous physiological processes. We know that testosterone levels, which are important in spermatogenesis, have a diurnal pattern with high levels observed during sleep. And interestingly, they have found that the duration of sleep is associated with the testicular size when it comes to young healthy men. However, again, treating sleep deprivation with hypnotics can have negative effect in more than one way. They can affect their sexual functions as well as the semen parameter. A little bit about management. Remember, there is nothing, when you diagnose a male factor infertility, there is nothing called expectant management. They will require some kind of a medically assisted reproductive technique to see them through their problem. So it could be an intrauterine insemination, it could be IVF, conventional IVF, or it could be intracytoplasmic sperm injection. How to decide? The decision can be taken by looking at what is known as a motile sperm concentration. For an IO, intrauterine insemination, to be successful, you would require at least a sperm concentration of 5 million per milliliter. So if you give some leverage for the wastage that happens during processing, in the original sample, you would expect to see something around 8 million per milliliter. So there is no point in doing IUIs for sperm counts of 2 million, 3 million and 4 million, right? So if it is less than 5, but more than 1, then conventional IVF has a place. If it is less than 1, they need to consider ICSI actively. Or there are other indications like for samples that are surgically retrieved, as well as if the original measures fail and the morphological estimates are. Remember, as we discussed originally, the majority of the cases of male infertility, we don't know what we are dealing with. They are idiopathic. And because it is idiopathic, the management is going to be empirical. It's not a targeted treatment. We just use that and hope for the best. So the treatment intention is to increase what is known as the intratesticular testosterone level. So we try to achieve this by either an endocrine manipulation or by giving plus or minus giving them antioxidants to reduce the oxidative stress and the oxidative stress related damage. Remember, in that context, it is detrimental to give them exogenous androgens, because it has been one of the treatment that was widely deployed some time back. What exogenous androgens would do is it will not increase the intratesticular testosterone level. However, it will have a negative feedback effect effect on the hypothalamus and the pituitary, and as a result, it will cut off the endogenous production of testosterone. So, and that will make matters worse for the patient, and it will be very difficult to correct it after. The treatment objectives are quite modest. We do not expect to achieve 100% correction. Our objective is basically to improve the chances of a patient who is to undergo an IUI, or push a patient who would otherwise require an IVF towards an IUI, or push a patient who would otherwise require ICSI towards conventional IVF, because the cost will be tremendously cut down if you can achieve a pregnancy through a conventional IVF when considering. So, and the other thing is, if a desirable result is obtained by some means, it's always worthwhile considering sperm cryopreservation, because people would not like to take medications lifelong, and there is no guarantee that this will last forever. So, in summary, male factor is the commonest of the causes for infertility. Till the diagnosing male factor revolves around semen analysis, although there are other things that have come up, but their utility is quite limited, like DNA fragmentation testing and other selective techniques for sperm that are to be used for ART processes. The majority of the male factor infertility cases are idiopathic, and therefore our treatment is empirical. There are numerous lifestyle factors that contribute towards male factor infertility, and these need to be addressed when you are giving medications or surgical treatment, because these are modifiable things. Thank you so much.
Thank you, sir, for that comprehensive insight to emerging crisis. Let me invite our next speaker, Dr. Milhan Batcha, consultant fertility specialist attached to Castle Street Hospital for Women, to deliver a lecture on male and female fertility preservation, especially with regard to cancer treatment. Over to you, sir.
Good afternoon. Thank you, Gayani. First of all, I thank FPA for inviting me for this session. The topic is fertility preservation. So, fertility preservation becomes important if an individual is going to lose fertility because of diseases or sometimes because of treatment. Majority due to treatment. I have nothing to disclose. So, the field of fertility preservation has grown immensely for the last 2 decades because of increased recognition of this problem. Also, development of enabling technologies. A person's reproductive capacity can be reduced, majority due to age. Basically, majority in the female. Luckily, the males, they retain their fertility for a long period. The other thing is gonadotoxic treatment. Chemotherapy, radiotherapy, etc. can cause gonadotoxicity and reduce, or sometimes they will lose their fertility, especially when it comes to treatment for malignancy. Certain other disease conditions, including some genetic problems, can lead to deterioration of the fertility, and also surgery, abruptly. Somebody have a oophorectomy or something, orchidectomy, certainly can lose their fertility. When the future fertility become compromised, the fertility preservation become a fundamental thing for them. And in females and males, both it can happen in the reproductive age, and also for pre-pubertal girls and boys. So, what are the indications for fertility preservation? As you know, malignancy is the chunk of the problem. More and more young cancer survivors, with the advancement of treatment, they survive. Ultimately, they would like to have a family. So most of the time, if they recover from the cancer, by the time when they come out from the disease, they want to have a family, they may not be able to do it, or if they lose their fertility. So these are the patients' majority. Other thing is, majority of these patients, by the time when they come to us, already they may have reduced fertility because of the disease itself, but major problem comes with the treatment. That is the chemotherapy and the radiotherapy. Chemotherapy is concerned basically the alkylating agents. Now, apart from this fertility issue, when somebody lose their gonadal function, the other problems comes into play, because the gonads secrete hormones. So then it can have effect on the pubertal development if they lose their gonadal function. Normally we need hormones, reproductive hormones for our normal day-to-day life, and for the sexual function that can affect by this treatment. There are a lot of non-oncological conditions requiring fertility preservation. Lots of autoimmune disease comes into the picture. The autoimmune disease itself can impair the fertility. Apart from that, most of these autoimmune conditions need cytotoxic treatment, so that can affect their fertility by the treatment. And certain medical conditions like benign ovarian tumors, when you remove ovarian tumor, ovarian cyst or something like that, then with that you will lose a lot of ovarian tissue, especially like endometriosis, multiple surgeries can remove the ovarian tissue, things like oophorectomy, so that ultimately they might end up with premature ovarian failure or reduce ovarian reserve. Certain genetic conditions like mosaic Turner syndrome, they will lose their fertility early, a fragile X syndrome, galactosemia, even beta thalassemia. So we will see their fertility fertility dropped at early stage, and Klinefelter syndrome in the male. And other things like hematopoietic stem cell transplantation. Before the transplantation, they need eradication of the pre-existing bone marrow. For that, they use chemoradiation. So ultimately, they end up with ovarian or testicular failure. So other aspect is age. As you know, when you go older, the fertility declines. So people, because of their socio-economic reason, they delay their pregnancy or the marriage. And as you know, the female fertility decreases gradually after 32 years and faster after 35 and 37. By the time when they reach 42 years, very unlikely to get pregnant. So what are the options available for us? For the females, I would say oocyte cryopreservation is, I would say, one of the first line and well-established method right now. It is increasingly preferable method because it gives autonomy to the female. Because the thing is, you don't want to have a partner or getting married, so you just freeze your the eggs. Then subsequently you can utilize it so without any problem. So only thing is, when you collect eggs, we just doesn't want one egg. We would like to have about 10-15, if possible 20, because that gives a good chance of pregnancy subsequently. And for that, they have to undergo a controlled ovarian stimulation protocol using gonadotrophins, that is FSH. Most probably we use an antagonist protocol. It will take only about 14 days. So we need some time for that. If somebody diagnoses cancer, if you have 14 days, we can go through a cycle and get eggs out and freeze. So the technology is vitrification. That's called fast flash freezing. So when human egg is the biggest cell in the body and it has a lot of water content, if you allow it to slow freezing, the ice formation can destroy the egg. So this flash freezing technique is the key of success. So that has made this survival better. Right. There are some instances you won't be will be having that 14 days of stimulation. So another thing what we do is, for these patients, we can get the immature eggs out. Whatever the eggs they are in the ovary, you can see when you do a scan, there are small follicles. We can aspirate those ones. Then you get immature eggs. But the thing is, you can't just freeze these immature eggs. We have to do the in vitro maturation. So we mature this egg and then we get mature oocyte and then we freeze. So that gives us a chance. Only this is allowed. I mean, we do this one only people who can't have these 14 days of stimulation and really they want to have the egg freezing. But for this, we need special technology and culture medias, etc., and the proper trained people. So that is the kind of a thing. That's why it's not always we don't do, because we prefer to do the mature oocyte cryopreservation. The other one is, as everybody knows, embryo cryopreservation. This is possible somebody who is already married or having a partner, and this is the most established option earlier, and it's a part of IVF, normal IVF program. If you have surplus embryos, we freeze. So again, the vitrification, that's called this flash freezing, allow almost 100% survival. So the survival is pretty good. So not to worry people when you freeze embryos nowadays. So as I said earlier, it's possible only unmarried or who having a stable partner or willing to use donor sperm otherwise. But the thing is, we know cancer treatment takes a long time, sometimes to recover and come. So by the time they recover and come, sometimes the family will not exist. So in that case, there will be a problem with utilizing these embryos and their legality. So that's why I said earlier, the first line option would be egg freezing. There's another technology what we use is, this is a newer, not very new, the ovarian tissue cryopreservation. That is, before starting cancer treatment or whatever the cytotoxic treatment, we get the ovary out of the body and freeze it. So after that, subsequently, once they finish their treatment and they are clear of cancer, they can come back and transplant this ovary tissue back to the system. Actually, this is recommended for people who are undergoing moderate to high risk toxic treatment, where we can't do, for various reasons, oocyte cryopreservation or embryo cryopreservation. This is the only option for pre-pubertal girls. Still, we can take these ovaries out on them and freeze. And as I said earlier, when somebody is diagnosed with cancer, they want to start treatment quickly as possible, so they don't want to wait. So if they don't have time to wait, of course, we can take the ovaries and freeze. Other thing is, this is not only a fertility preservation option. So when you put back the ovary to the system again and start producing follicles, the hormones become normal. So that's the other advantage you have with this method. The first pregnancy after ovarian tissue cryopreservation and subsequent transplantation was way back 2004. Then immediately in 2005, the second one. And after that, it's just surged up. I think right now there are about more than 200 reported cases, but there are lots of unreported ones. So I think it's very commonly practicing now. So what is the technology we use? So usually what we do is we harvest this ovary by using a laparoscopy, take the ovary out. Usually we try to remove only one ovary because, as you know, normally when somebody goes to chemo chemotherapy, we can't predict how much they will go for premature ovarian failure. Some, after about 2-3 years, they recover. So if you take one ovary and keep one ovary inside, still sometimes it can recover, sometimes they might get pregnant naturally. But still they have a chance to, if they go through premature ovarian failure, still the ovaries are frozen, so they can get pregnant after that using those eggs. So that's why usually we take only one ovary. But if somebody is going through radiotherapy, of course, I would recommend to take both ovaries out and freeze. What we need is only the ovarian cortex. So what's the thing? What we do is we take the ovary, cut it, and take the medulla out, take only the cortex, make small pieces, 2 millimeter to 3 millimeter, 4 milliliter, and freeze. So the freezing technology again, there are two methods I said earlier: vitrification, that is the flash freezing, or the slow freeze. So nowadays, still the best technology is the slow freezing, and the success rates are better with slow freezing than the flash freezing for ovarian tissue cryopreservation. Once the patient is clear from the disease, they come back, then we put those ovarian tissue pieces to the position where it was taken. So it can be done either, now I said earlier, we will remove only one ovary, the other ovary will be there. Sometimes the ovary goes into kind of fibrosis, and you cut that ovary and expose to the vasculature. You need to have vasculature, otherwise once you put the pieces, it will not grow. So make sure there is enough vasculature is there, and then you can suture it. Otherwise, sometimes you can put the interseed and cover it. Otherwise, you can put it to the same place where retrieve the ovary, but you have to dissect to the peritoneum and put it. There are other methods also. What we need is eggs. So even if you can put under the skin and then it allow to grow and take the egg out, still you can do it. But nowadays, still the success rate is better if you do this technique, because I don't know why it is, but normally the success rate is higher if you place where it's supposed to be there. Okay. And what is the efficacy and the limitation? Ovarian activity is restored in more than 95% of the cases. Some studies have shown that means when you put the ovary back, start producing egg, hormones become normal, then the all menopausal symptoms disappear. So this happens almost 95%. The mean duration of function of this ovarian tissue can vary from 4 to 5 years. So it's not going to be normal as the normal ovary. And some studies have shown even 7 years they were persistent. These are one of the studies, 445, large number of cases, and before various indications. This was between 1997 to 2013. The mean age was 22. They are very young people they are used. After the procedure, some of them have died, 54% by the time. So that's why, although they freeze their ovaries, they may not be able to utilize it. 25 of them have come back for treatment, again to put the ovaries back, and 21 had their ovarian transplantation. 7 got pregnant in this particular study. 68.5% have that got normal in their hormones, and 31 still didn't get. There are reasons for that, so I'm not going to talk in depth of those reasons. And also this review showed a very high satisfactory level, because there's 96% of the patients were very satisfied about this procedure, even those who did not require reimplant, because addressing their fertility issue before starting cancer treatment give them kind of a positive psychological impact, because they know sometime, cancer treatment, when somebody is diagnosed with cancer, they have to go through so much, and if they know that they can't get pregnant even after the treatment, they are disasters, that they will be like devastated. So if they know that, if I come out of the problem, if I can have a family, then they'll be facing very positively for their treatment. So that gives kind of a sense of hope. So that actually play a very positive role for their recovery. So when it comes to age-related fertility decline, because nowadays people are trying to delay their pregnancies because of the carrier and various reasons, I would say the best option is to use oocyte cryopreservation, and also for non-oncological condition. Sometimes for cancer patient, we do another thing, so combined technique, because if they have time, we take the eggs out, and same time we take the ovary also, freeze that also. So then combined FERT will give a very high pregnancy rate. So that's we do. Even in Sri Lanka we do that one. Another thing is, if you don't have all these things, we sometimes recommend to give GnRH agonist pre-treatment before starting cancer treatment. GnRH, if you give to a person, the ovaries they go to kind of a menopausal thing. The ovaries, the primordial follicular development season, and then their sensitivity to damage by these gonotoxic agent will be less. So that is the theory behind that. But it doesn't have much evidence. But thing is, if you don't have any other option, this is another thing you can do before starting cancer treatment, especially chemotherapy. Another method people used to practice from good old days is ovarian transposition. That is, bring the ovaries away from the radiation field. So if this is possible only pelvic cancer, where you can give only radiotherapy. If you give chemotherapy, it's going to get destroyed. So only if radiotherapy can cure the patient, then of course taking the ovaries out will help minimize the damage. And subsequently, even if you take from the tube, it's tube also with that. People have got pregnant naturally after that. But sometimes it's not. Then we have to get them back down, because if you want to go for IVF also, then of course you have to bring the ovary back again to the normal position. So these are the kind of options we have for female. What about males? As you know, everybody, sperm cryopreservation is the only established fertility preservation method for adult and adolescent male. But the problem comes sometimes when the people are very ill sometimes. In that case, and they are psychologically, they are mentally, and they are physically. Sometimes they may not be able to produce sperm during these illnesses. So in that case, sometimes you need assistance to get the ejaculation done. And for that, sometimes you use electric vibrators or sometimes electroejaculation, or sometimes even you can do it by surgically as well. Another technique what we use is testicular tissue cryopreservation, like ovarian tissue cryopreservation. But the success rate is not good as ovarian tissue cryopreservation, so still it is experimental. To summarize things, fertility preservation is a fundamental thing. If somebody wants, it has to be provided and give hope for cancer patients. So embryo cryopreservation and oocyte cryopreservation are well established option for females, and ovarian tissue cryopreservation is no more considered as experiment. It is done and been proven. Ovarian tissue cryopreservation not only helps to have the fertility preserved, and also it normalizes reproductive hormones once it been placed back to the system. For males, sperm cryopreservation is been practiced for a long time, and testicular tissue cryopreservation is still considered as experimental. Thank you for listening.
Now, the panel is open for the discussion and the questions. If you have any questions, you may ask now. Well, I will ask question from you, sir, from the Batcha, sir. Nowadays, the ladies are more career-oriented. They postpone pregnancy. If they're going for a fertility preservation or any other form of a fertility preservation before marriage or after marriage, is there a particular age limit or there's a better age to do so?
So as I told earlier, the female fertility declining. The decline is pretty faster after 30 years. Slower after 30, after 35 is very fast. So I would say better do it before 35. But again, there can be individual variation. So normally before doing the procedure, we will do an assessment of the female. That is to assess the ovarian reserve. If the reserve is okay, we can wait a little. But before getting things worse, it's better to freeze. I would say less than 35 years the best, at least before 35 years.
Any other questions?
good evening everyone මම මගේ පහසුවට සිංහලෙන් කතා කරන්න මේ ලංකාවේ මේ වෙනකොට මේ මද සරුභාවයේ තියෙනවානේ දරුවන් නැති එක මේක ලොකු ප්‍රශ්නයක් වෙලා තියෙනවා. එතකොට මේ පෞද්ගලික රෝහල් වලින් ගොඩක් මේ සඳහා ප්‍රතිකාර කරනවා. ඒතකොට ලොකු වියදමකුත් යනවා. ඒතකොට රජයේ විදිහට මේ වෙනුවෙන් යම්කිසි ක්‍රියාමාර්ගයක් මේ වෙනකොට අරගන්නවාද එහෙම නැත්නම් රජයේ විසින් මේකට දෙන දායකත්වය මොකක්ද කියලා දැනගන්න මම බොහොම කැමතියි. ස්තුතියි.
To translate that, those who can't understand the Sinhalese, what he asked is, in Sri Lanka, we have the assisted reproductive technologies are mainly in the private sector. So the people who are spending a lot of money, because everybody can't afford that. Because of that, he's asking whether as a government, are there any policies or any plans has implemented already to help those people who are in need for the assisted reproductive techniques?
මේකට සිංහලෙන් උත්තර දෙන්න. මේක ඇත්තටම සබ්ෆර්ටිලිටි අපි මුලින්ම ට්‍රේන් කර එකන තමයි ડોક્ટર බාචා. ඒකට ඒ ට්‍රේන් කරන කාලේ තමයි අපි රජෙන් ඉල්ලුවේ මේ අපුහුණු වෙලා එනවා. ඒ නිසා එනකොට අපි මේක IVF කරන්න යුනිට් එකක් ගාල්ලේ හදන්න කියලා යෝජනා කළා. නමුත් අවසනාවකට එකම රජයකවත් ඒක ප්‍රයොරිටි එකක් උන්නේ නැහැ. ඊට පස්සේ අපි හිතන්නේ දැන් අවුරුදු 7-8කට ඉස්සෙල්ලා ඊටත් ඉස්සෙල්ලා මම හිතන්නේ කාසල් ස්ට්‍රීට් එකේ හොස්පිටල් එක හදන්න කියලා සියලුම දේ යෝජනා කළා. නමුත් තාම රජයේ රෝහලක ඒක එස්ටැබ්ලිෂ් කරන්න හැකියාවක් වෙලා නැහැ. අවසාන ප්‍රශ්නේ තියෙන්නේ ඇත්තටම දැන් මේ ගොඩක් heart attack එකක් හැදුනහම මිනිස්සු හිතන ඒක තමයි ඒක ලොකු රෝගයක්. ඒකට ඉක්මන් ප්‍රතිකාර කරන්න ඕනේ. ඒක නමුත් කවුරුත් මේ subfertility කියන එක ඇත්තටම ඒකෙන් suffer කරන අය තමයි දන්නේ ඒකේ තියෙන වේදනාව. ඇත්තටම ස්පෙෂලි Tamanට ප්‍රතිකාරයක් තියෙනවා නමුත් කරගන්න සල්ලි නැහැ. ඒ වගේ අවස්ථාවකද මොකද කරන්නේ කියන එක අපි හැමදාම දකින ප්‍රශ්නයක් නේ. Tamanට ගෙවල් ලුකස් කරලා තියෙනවා සමහර තියෙන දේවල් විකුණලා යනවා. ඉතින් ඒක අවසනාවකට එකම රජයකවත් ඒක ප්‍රයොරිටි එකක් උන්නේ නැහැ. තාමත් අපි හිතනවා.
මාත් ආයේ සිංහලෙන් පොඩ්ඩක් කියන්න ඒ ගැන ඔබතුමාගේ ප්‍රශ්නෙට. ඔව් දැනට තත්ත්වයේ ගත්තොත් IUI වගේ ට්‍රීට්මන්ට් නම් අපේ කාසල් සීට් එක කතා කරොත් තියෙනවා. ඒක සම්පූර්ණයෙන්ම නොමිලේ ලබා දෙනවා අපි එහෙ. IVF එක ගත්තොත් දැනට බිල්ඩින් එක හදලා ඔල්මෝස්ට් ඉවරයි. අවුරුදු 2000 අපි කොවිඩ් කාලේ පටන් ගත්තා 2019 මුල් ගල් තියලා ඊළඟ දවසේම මොනවාද ලොක්ඩවුන් එකක් ආවා. ඊට පස්සේ ඔක්කොම නතර වෙලා දැන් කොහොම හරි බිල්ඩිම හදලා ඉවරයි. දැන් පොඩි ෆිනිෂර්ස් තියෙන්නේ. දැන් ඉක්විප්මන්ට්ස් තමයි ඕනේ. ඒක ලොකු ප්‍රමාණයක් මුදල් ඕන. තාම ඒක අනුමත වෙලා නැහැ. ඒක තමයි අල්ප තත්ත්වය. ඊළඟ ප්‍රශ්නේ එන්නේ අපිට ඒක නෙවෙයි. පටන් ගත්තට පස්සේ ඒකට වැය වෙන රිකරන්ට් එක්ස්පෙන්ඩිචර්ස්. ඒ කියන්නේ කාල මුදල් ප්‍රමාණයක් ගෙඩන් වෙනවා. ඉතින් ඒකත් ලබා ගන්න ක්‍රමයක්ත් එක්ක තමයි ඒක එන්න ඕන. ඉතින් ඒක අපි ගත යුතු තීරණයක් නෙවෙයි. ඒක මම හිතන්නේ policy makersලා ගත යුතු තීරණයක් කියලා මම හිතන්නේ. ඒගොල්ලෝ කොහොමද ඒක කරන්න කියලා කාටද IVF දෙන්නේ? මොන වගේ criteriaස්ද පාවිච්චි කරන්නේ? මොකද ඒවත් විශාල ප්‍රශ්න ඉස්සරහට තියෙනවා. අපි හදිස්සි වෙලා ලංකාවේ එවැනි දෙයක් නොමිලේ ලබා දෙන්න ගියාම මොන වගේ කට්ටියට දෙන්නේ? කවුද ඒක කියන්නේ මෙඩිකලි අමතරව අපිට අනිත් දේවල් බලන්න වෙනවා. මොකද සමහරවිට අපිට එනවා කාසලකට සමහර අය එයාගේ family backgrounds ගැන ඒවත් වැදගත් වෙනවා. මොකද husband කුඩු එහෙම ගන්නව නම් එහෙම මොනවා එහෙම ගන්නව නම් එවැනි පරිසරයක හැදෙන ළමයෙක් හදන මේ වගේ දෙයකට අපි දෙනවා. ඒක අහතු ප්‍රශ්න ඒක සමාජයේ කතිකාවක් විසු දේවල්. මොකද මේක දෙන්නේ අපි ආණ්ඩුවේ කිව්වහම ජනතාවගේ වදු මුදල්. ඉතින් ඒ වගේ දෙයක් කරද්දි කාටද දෙන්නේ? ඉතින් ඒ වගේ දේවලුත් හිතන්න ඕන මම හිතන්නේ.
Good evening. I have the question. Can you explain the IVF legal framework in the Sri Lanka? I have the second question. If you can answer in this question, you can answer what is the method having in the Sri Lanka for spinal cord injury couple?
Legal framework at the moment, there's no legal regulations at all. But very recently, I think after about, this is from about 2012, after a long struggle for about 12 years, we have been able to bring up at least some guidelines to IVF centers so that they are bound to give some ethical and rational treatment procedures, practice some rational treatment procedures when they provide services to the public. So that is the start. I know, like, we were actually planning to establish something like a HFE, that is Human Fertilization and Embryology Authority, like in UK. But unfortunately, that involves a lot of changes. But for a start, we have got the ministry to, actually we have drafted guidelines, and now it's perhaps within the next 3-4 weeks it will be out for the IVF centers to practice. For the people with spinal cord injuries, there's no established treatment practice. So again, with regard to that, is again we'll go with the kind of injury, and of course at the end of the day, at the end of the day, if it's a male, we are looking at getting a sperm sample. So there are various techniques that you can adopt to do that, and of course they might have to go for some kind of assisted reproduction treatment if they want to achieve a pregnancy.
So I currently did my undergraduate study research on subfertility, but I'm a demographic student, so I did how subfertility affects how the treatment seeking behavior of currently subfertile married women. So I tried to address the demographic factors, socioeconomic, cultural factors, but this was a very small study. So I just want to know, what are your comments about the treatment seeking patterns and behaviors among women, specifically women in Sri Lanka? Do they have fertility before they come to treatment? Because in my experience, they had no idea about subfertility unless they tried to approach several treatment seeking options, because like they had to go for like 3 or 4 treatment seeking options to pick one, and most of them were very culturally biased. Their ideas revolved mainly around the cultural factors. So what are your ideas about that?
I think with regard to public awareness and knowledge with the kind of treatment options that are available are very limited. Of course, it depends on what kind of level of education and knowledge about sort of education level and all. And the other thing is, now if you look at the woman who wants a child, they do anything to have a pregnancy. You just need to get a weekend paper and look at the advertisements that are there with regard to various kinds of treatments options that are available for fertility. Unfortunately, these are also not regulated. We know they are 90% they are not true, and also kind of misleading information that is rampant. I mean, none of the treatment procedures like IVF is 100% successful, and you can mislead people, and also they spend a lot of money, and people go from one place to another. That's a very common thing. So if they go to Dr. A, and in 3 months if they don't get a pregnancy, they go to Dr. B, then Dr. C, and sometimes we see the same thing being done over and over again, and they age, and they go, when they are about 39, 40 only, now they realize there are other options, and that's a very common problem.
I think social media plays a lot of big part, because people are basically oblivious as to what they need, and most of the clinicians that practice, they are unaware of what should be offered. So they just give them what they are comfortable with. Again and again, they undergo the same treatment without realizing that they need to go to the next step. That is, I think, what Prof. Kaluarachchi was trying to elaborate also. And social media plays a big role. They ask in these social media forums that are there. And there are people who might not have the best interest of the patient in mind. mind. So they will just direct them to a particular individual or a particular center. So that we see that happening a lot. And ultimately, they might not get what they really deserve. Now, there are two things that have happened in the recent past. One thing is the code of conduct that Prof. Kaluarachchi was talking about. We have devised that, and it's to be inked by the ministry and the government, so that that will come into play in recent future, in the very near future. So that includes that the people who are providing these services will be duty bound. Who should be there, what level of knowledge should they have, and who should be in charge, and what should be offered like. We have formulated an association of reproductive medicine and surgery specialists. Dr. Batcha is the president of that. So that will also take these things into account, and we plan to address these things as well in time to come.
Just one thing to add. I agree with you that most of the people have that kind of a treatment seeking pattern. But I have also noticed that there are people who are far ahead of us as well, because there are Facebook groups who discuss about different doctors, different treatment types, whether it works or not. So that part is also developing, or it's happening rather slowly. But I think women are also trying to think about what kind of a treatment they really want. So I think we need to encourage that happening, so they will, at the end of the day, will have a better treatment. Yeah.
I think a place like FPA would have a big role to play in terms of, because fertility treatment is a big business. If you really look at it, people exploit. What we see mostly is exploitation of subfertile couples. That is the sad part of it. Knowing that your treatments are not going to work, people keep on giving various medications, and sometimes the cost, we see sometimes the drug that is costing 5 rupees being sold at 5,000 rupees. So that kind of unfortunate exploitation of this situation is there, because people will do anything to have a pregnancy. So that's the sad part of it.
Yeah, that's why it basically you need regulation here. So here we don't have regulation right now. So we're trying to do it. Our politician also doesn't understand this thing probably. So I think that is the way forward. Have a proper regulation. Then these unethical practices can be eliminated. And then all the awareness programs will be all well regulated. Correct information could be provided to the patient. Yeah, that should be there.
So as you know, there is a big demand in the public for the subfertility treatment. So as you discussed and as we aware, we know in our government sector, there are only limited investigation and limited treatment opportunities are there. So but now in some places in Sri Lanka also, there are some sort of higher treatment facilities, and there are higher places with all the facilities to do some sort of treatment for the patient, for the parents willing to have and affordable for those services. My question is to the college or to the Ministry of Health, is there any guideline to the government medical service, government doctors to refer them to those places, how much they should go these investigations, and after that what is the investigation like that, if there's any guideline to follow?
So that's, I think, what Prof. Kaluarachchi was saying. The guideline or the code of conduct that we help to form explains the whole cycle from the beginning to the end. And also it explains who are the people who are qualified to practice IVF, and that all the centers should be registered in the medical Ministry of the Health, and they have to follow a certain guideline that is issued by the Ministry of the Health. So there will be hopefully a committee who's looking after this center. They might visit those places maybe once in a while. That's our plan. We need to have some kind of that is similar to HFA that's in UK. In the beginning, it may not work, but hopefully with time, things will get better.
What your question you are probably was asking us, whether there's a referral process.
Referral process
Yeah.
and any
Yeah,
guide.
unfortunately, there's no standard practice in the referral process, except, it's haphazard. I think some people would do refer to a knowing, because the thing is, fertility treatment, you might start with a very basic level, and you must have a plan for the couple, because there's no point going on treatment for 10 years and with the same kind of treatment. So if you do practice basic treatment for maybe 6 months, 1 year, if you don't get pregnant, you must go to the next level of treatment, like doing induction of ovulation and IUIs and things. If it doesn't work within 6 to 8 months, then you must offer at least to the couple, okay, this is available, at least the next level treatment is available. And that kind of educational process and making them aware of available facilities and tell them where to go, it's not happening in a standard way. It's very haphazard.
You might not be aware that subfertility or infertility is a recognized subspecialty under Obs and Gayani, and there is a training program for that. And there are people who have trained and come back after their overseas training. Dr. Milhan Batcha was the first, I am the second. Then there's another lady in Kandy, Dr. Deepani, and Udara is the fourth. So we are manning stations and people know about us. It's a matter of referring. So even in the government sector, they can refer us. At least even if the facilities are not there, we can at least counsel the patient as to what to be done and make a management plan for them so that they know what to expect as they go through their treatment journey. If that is not happening, that's unfortunate because we are there. Dr. Batcha is at Castle Street. I have joined the university. I am at Kaluarachchi Teaching Hospital. Udara is at Ragama Teaching Hospital, North Colombo. Deepan is at Kandy, and hopefully Gayani will go and take over goal in the next couple of weeks. So there are people. So it's a matter of referring to those qualified people.
Thank you. That will be end of our mini session. That's the last session of the conference. Thank you very much for your patient listening and collaborative discussion. Thank you very much.